Welcome back to the Physio Matters podcast. This month in association with exerciseprescriber.com, and this is session 67. This month we talk tendons with a man who needs absolutely no introduction, Pete Malliaras. As he needs no promo from me really, that gives me a chance to give you a update on Big R's conference news. The Manifesto for Reform is well into its editing phase and looking like an absolutely amazing document. The detail and content really is staggering. Look out on all the social media feeds for updates on that, as they will be imminent. Workshop bookings for the conference are imminent as well and may well be available by the time this podcast is released in just a couple of days' time. Watch out on our social media feeds again for how to book this via the form, which will be on reform.physio/conference website. It should be nice and easy for you to do. Book nice and quickly to avoid disappointment missing out on your favourite workshop. If you haven't got a ticket yet, head to the same link to buy one. Check out our Twitter, Facebook and Instagram feeds for how you can enter a competition to win a free ticket to the conference. Don't panic if you already have a ticket though. If you win, we'll just refund the cost. You can't ask much more than that. But a free ticket to the Big R's, what a prize that is. So on to the podcast for this month. It's an absolutely brilliant chat. Prepare to learn loads about tendons. See what I did there? Loads.
Delighted to be here today with Pete Malliaras, who has come over from Australia for a stadium tour, sellout stadium tour across the UK, and kindly has dropped by. He's got a course in Manchester on Wednesday that two of our team are going to be going along to, and he's kindly dropped by today for a chat about all things tendons, which he knows a few things about, so I'm really looking forward to jumping in with that. Like always, the first question, Pete, is who are you and what's your story?
Thank you very much for having me, Jack. Thank you. I appreciate the invite. So basically, I'm a physio from Melbourne, and I've been working as a physio for 22 years. And, interest, as you say, in tendons have been... So I sort of started my PhD in tendinopathy when I was 5 years out, and basically has continued from there. And what I do mainly these days is, I variably worked with patients and doing research over my whole career. And now I work 1 day a week in the clinic, and then I work doing research 4 days a week at Monash University.
Right, fantastic. And so where did the interest in tendons come from? I have to ask that question.
Yeah, look, it was really just serendipity. It was just meeting the right people. So I did my PhD with Jill Cook. I was her first PhD student, and basically just... got into La Trobe University, where I did my undergrad, and it just all went from there. So it was more sort of availability of resources and people than anything else.
Right.
But it just grew and grew from there, my interest in tendons, yeah.
And so the coincidence of sort of people and characters and opportunities that knocked, that's certainly sometimes what drags people into just getting some research stripes, but they often then go and find something else that's more their bag. Whereas you've just doubled down on the tendon thing. So it really has sort of been something that coincidentally is what interests you as well.
Absolutely. So it's just, I mean, when I was a young physio, I wasn't having a good time for the first 5 years after I finished. I was disillusioned. I was thinking I'm going to either leave the profession, or I'm going to find something that really I love. And that's what I did. And I think, look, I really enjoy problem solving and research. And I have been able to find an area that I love problem solving in, and that is what I'm doing now. So, I mean, I love tendinopathy, but I love research. I think I can say I love research more.
Really? The process of research.
Yep, I do.
So
I do. I love
a
it.
combination of researching tendons must
Yep.
be just
It's,
the dream gig then.
It is. It
Oh,
is.
fantastic. No, it's great. So as we've just been chatting a little bit before we got on air about the questions that I've had planned, and it's a funny one because we've visited tendinopathy before on the podcast. You can imagine every body part it comes up, but also we did 2 podcasts early doors in our series right years ago with Seth O'Neill, now Dr. Seth O'Neill, before he was pre-fame Seth O'Neill.
Exactly.
And so whilst we're going to naturally, I'm not going to apologise for overlapping with that because time has passed and it's an evolving area. And so some of the questions are what on the surface seem basic, but then when I was trying to answer them myself and thinking like, wow, I know how much these things have been changing from my own reading. So I want to ask the first one being, what is tendinopathy?
Look, that one thankfully hasn't changed that much.
Good.
So basically, we know it's so the actual term tendinopathy. We sort of talking about any pathology or pain of the tendon. So any pain or pathology related to the tendon is what we define as tendinopathy. So it could be just a thickening of the tendon for some people without any pain. It could be usually it's pain and pathology, and that's our sort of classic tendinopathy definition. But these injuries, they affect pretty much every part of the body. So you're looking at the shoulder all the way down to the Achilles and the plantar fascia, and they also can really affect people in terms of their function. So they're and this is one of the things that really interests me about tendinopathy. It's so broad. I mean, you've got tendinopathies in the shoulder that are very different to tendinopathies down into the foot, and they behave differently. People have different presentations. So it is. Look, you're right. It's very hard to actually define tendinopathy, but I think what I'd come back to is a change in structure as well as change in function, and obviously pain is the key factor.
So whilst I don't want to really take a deep dive into the history on this because we have elsewhere, but one of the reasons for me asking that question is because there has been some controversy over the plus or minus inflammation discussion. It doesn't necessarily sound like that's relevant to what is tendinopathy, though, because it's like you said, it's almost a diagnosis within sort of pain emerges from or around a tendon. So what's the latest on how relevant that is? The sort of itis osis debate that's gone on before.
Yeah, look, so itis means that there's some sort of inflammation in the tendon, and what we've come from is sort of a thinking that doesn't exist, that doesn't occur, and that was from some older studies where they showed that really there didn't seem to be any signs of inflammation in these older studies, but now we've got a lot of groups around the world that are looking at inflammation, and there are signs of inflammation and inflammatory signalling, that's for sure, and that's becoming more recognised. So it's itis we still don't use because it's still contentious, and it's not really, we haven't got any consensus about what the inflammatory nature of tendinopathy is. Another problem is we don't often see tendons at the start of their course. So whenever we have evidence about inflammatory issues in tendinopathy, it's always later on down the track. Now, later on down the track, it's more likely to be less inflammatory. So we don't call it itis anymore. So itis is not the term we use, and we don't call it osis anymore. And the thing with osis is it implies that there's a degeneration in the tendon. So we don't call it osis, we don't call it itis, we call it tendinopathy, and that's in the middle. It doesn't imply any type of pathology. So it doesn't imply that there's a certain pathology there. It just basically is a pain and pathology and dysfunction within the tendon. We don't know yet, and that's the problem. We actually don't know what the underlying biochemistry is, and the biological pathways. What we do know, though, is that there probably is inflammatory signalling, and we didn't recognise that before.
Sure. And so a movement towards an umbrella term that's accurate but still not necessarily that specific because it needn't be at this point in time.
Yep.
Then because with the
Yep.
with the OSIS, covering the OSIS word, it's helped us bridge to my next supposedly easy question, which is what happens to the tendon and why?
So what happens is, again, quite complex, but it can be summarised as you have a thickening of the tendon. So people can sort of recognise that with Achilles, you get a thicker tendon. That's mainly related to increased ground substance, so increased sort of water-binding proteins. Then you also have increased cells. Now, the tendon doesn't have an infrastructure for adaptation to load very easily. So it basically struggles to actually adapt to load. It doesn't have many cells, doesn't have a very good blood supply. So when you load it, it starts to then really try and increase that infrastructure and increase the cells. So you get more cells, you get more, they sort of tend to produce these proteoglycans, the tendon becomes thicker, and then you've got eventually it doesn't quite always work out where the tendon then adapts, and you can sometimes get a broken down tendon matrix. So the matrix then is affected, and then finally you get an ingrowth of blood and nerve vessels. So they're the sort of hallmark features of pathology that we see, and that's been summarised in the continuum model. So Jill Cook and Craig Purdom continuum model, which is a very popular pathology model. Basically, they talk about a reactive tendon where you've got a thickening of the tendon as well as increased tendinocytes, and then going over into degenerate where the matrix is affected as well. So they're the sort of phases that we look at. The problem with that, you're probably going to ask me about this, but the problem with the continuum model is it doesn't relate quite well to pain. So we know that it's a great model in terms of very forward thinking and pathology, pathogenesis, the order of pathology. I don't use it clinically myself because it doesn't relate that well to pain. Therefore, we know that no imaging really relates closely to pain, and that's the issue. But they're the hallmark pathology features.
What's interesting with that, before we really delve into the sort of pain side of it, is that unlike elsewhere in the body, there is still it's rare, isn't it, to find a painful tendon that is squeaky clean, shall we say, on imaging. In that there isn't no matter what depth of imaging, we couldn't find anything. That's whereas elsewhere, you got a sore knee or sore back that truly can be, and so. Where might that be relevant, and therefore might the continuum model have more to tell us about pain and pathology than we sometimes think?
Yeah, look, I think certainly that's true. You don't tend to get pain in the tendon if you haven't got some pathology. So there's always pathology there when you've got pain. Well, not always, but it's very unlikely. So I think potentially looking at early changes in pathology, as the continuum model tries to do, there's merit in that. There's definitely merit in that, but we're just not there yet in terms of understanding these early changes and knowing what they mean. So the promise of reactive tendinopathy is, from a pathology point of view, is that it will allow us to say, okay, this person's got a reactive tendon. We need to do something that is different here to prevent them from going to degenerate tendon. Now, that's fine, but we just don't know which ones we need to prevent. And if we see reactive, we have no way of knowing whether it's just going to take its course and become normal, whether we do nothing or whether we change their load. So it's just a not very well understood area at the moment in terms of changing load in response to pathology.
But as with the other conditions, body parts that I've described, there isn't a decent correlation between level of pathology and symptomology, and that's where it does seem to correlate with elsewhere. And I imagine that's been. I'm saying it as speaking potentially opinion as fact there, but I imagine that hasn't necessarily been shown to be different yet.
No. No, pretty much. You're talking about the lack of relationship between symptoms and pathology. Oh, absolutely. This is the what we know at the moment is that imaging doesn't relate very well to pain. For tendons, like with all the other conditions, imaging doesn't prognosticate. So there's no evidence that it actually, for certain types of imaging, it's going to mean you're going to be worse off or not going to recover. Those two things we know. However, a big caveat on that is that the evidence at the moment is really not very good.
Right.
So this is what I talk about in my courses. That's from my own clinical experience. There are certain types of tendinopathies when you look at them, you think this is going to most likely prognosticate.
Right.
But this is a small group of people. It's sort of the 5%ers or the 10%ers that you've picked up from clinical experience to say, this is different.
Right.
This one's going to be, this one is possibly, they've got all these different things in there. Some people call them delaminations or tears, or a tendon that looks very, very different to the normal tendon. And you can, not always, but you can see that sometimes they struggle. And one of the reasons could be the pathology. So I don't think we know yet. And I'm going to probably repeat that phrase many times during this podcast, because there are many things we don't know and fully understand, unfortunately.
No, but that's good, and that's part of why we have you in here, is because you can probably tell, and our listeners know, we've seldom got any dogmatists in here that think they've got a magic answer or are convinced, and so that willingness to say we're not sure yet, but to still then also not equivocate and say we therefore don't know what's not right as well is important to us. In that sense, then, with the sort of pain pathology not matching on well, what's your take on why then tendons become painful?
I think it probably has to do with some sort of biochemical response that happens in the tendon. So it's not clearly related to pathology. So the pathology itself per se is not the issue. So it most likely is some sort of biochemical response. So we do know that there are multiple biochemical changes that happen in the tendon. So people talk about neuropeptides, neurotransmitters, and cytokines, and all these things that we don't fully understand again, but they change in regulation when you've got a tendon problem. So it's most likely this biochemical change. Some people have it, some people don't. The other thing is, it's also, obviously crosses over to our understanding of pain itself and pain perception, and when something becomes painful and when it's not painful. And that's obviously also driven by other factors like people's, attention and cognitive factors. So it's really an interesting area, but the best guess at the moment is that some people have biochemical changes that are not present with the others that don't have pain.
Right.
And a good example of that is looking at rupture of the Achilles tendon. So if you got a person who basically ruptures their Achilles, they don't have any pain before generally, and they just rupture without any warning, and but they have the same pathology as someone who doesn't rupture when you look at imaging. So it's interesting. But they don't have any pain, and they've never had pain. So it sort of suggests that although the pathology reaches a similar point, there are other biochemical changes within the tissue that mediate whether someone's going to have pain or not.
Okay, so we're talking about some biochemical, what we'd argue, bottom-up factors that might chemoreceptive, nociceptive function, and then we've got what you mentioned before as being what would be classically considered a more top-down sort of neurological approach that it considers perception and cognitive factors and variables.
Yep.
Gun to head, where do you feel, if you had to, obviously it would be silly to have to pick one, because of course they're all playing a part, but with regards to tendon pain, do you feel that this is more of a bottom-up phenomenon or more of a top-down phenomenon?
It's probably more of a bottom-up. I think that's the consensus, and I would agree with the consensus based on the current evidence. It's more of a bottom-up. It seems like it is a often load-related, localized pain. It seems like it is a bottom-up for most people, but we need to consider. I think the key thing that I've talked about over time, and this is one of the things that we're starting to look at with our research as well, is even though it's bottom up, you obviously need to consider the person a lot with that.
Sure.
And it's still the fear of damage and fear of movement is, I believe, one of the most important factors.
Right.
And it's probably more so than sort of the anxiety, depression, other things that you get with some of the other pain states like your back pain and other things. Chronic back pain. So I think fear. Tendons, for some reason, people do display lots of fear, and I think one of the things is will it rupture? Will it rupture? Will I damage it?
Sure.
And that's even though it's a bottom up, as you say. I think it is bottom up, but it's there's lots of other things going on for most people, and some people then become, start to have some many top down factors as well.
And there can be people sometimes underestimate the fact that you can have a arguably more bottom up causal rationale for diagnosis, analysis, call it what you will, when we think about why this has emerged in this person in this moment in time. But then it could be that there's either top-down barriers to recovery, but also you might need what Joe Gibson would call cognitive-rich rehab, where essentially your rehab is actually seen, or from the outside at least, to be more top-down centric, even though you're trying to solve what is arguably a more bottom-up heavy feature. I hope I think that was a tongue twister. I don't know if that makes sense.
That's a great term. I've never heard that term, cognitive-rich rehab. But that's excellent. That pretty much summarises what I do with tendons.
Right, well, I certainly want to declare that is not an original idea from me. That's certainly me piggybacking Joe Gibson. I hope I've not worded it wrong, but that's about where she says it. So
no, I like that.
No, it's certainly what we try to do in these worlds as well. And I think that's what's interesting then, that we know it's going to be a bit of both, but we also recognise that regardless of what we find as to what we think is the reason for something, then the actual rehab journey doesn't necessarily map that. And that's one of the things I wanted to then come to, because we kind of skipped past a little bit on the why, because I'm more question what happens to the tendon and why, and naturally it's such an interesting topic that we ended up sort of rabbit holing that a little bit. So I wanted to try and talk a little bit about some of what you feel are the disposing features that mean that someone might have an event that then, for want of a better term, breaks down the tendon, or that as a person breaks down their function, and then also potentially some of the protective factors, which will help us lead to the why that might occur in someone.
So basically, the most important factor is load. So it's the load, and primarily it's change in load. So the change in the sort of loading that's going to really affect the tendon. So it's going to be like stretch. I talk about stretch, shorten, cycle load a lot, and it's really walking, running, jumping loads that are going to be quite high load for the tendon, and it seems to be things that are done quickly, because the tendon, especially lower limb tendons, they basically work as springs when we're doing functional activities. The muscle is primarily isometric. The tendon stores energy like a spring, and it really is loaded quickly and also heavily. So that is sort of the type of. That's the biggest risk factor by far, and it doesn't matter who you've got. Even someone who's just walking and develops a tendon problem, still walking is probably the biggest factor for them. But obviously, then you've got all your other factors that are non-load related. So load's always the biggest factor. Then you've got things like how old a person is. Females in menopause can be really troubled with tendon problems. Metabolic presentations, they can also be risk factors. Like cholesterol is a very strong risk factor for tendinopathy. We know that from multiple studies. Diabetes, all of these metabolic issues, menopause, as I mentioned, genetic factors and predisposition of family. It's not uncommon that I'd see patients who. I saw a girl the other day, 25, ruptured her Achilles. Mum was in there with her. She's ruptured her Achilles twice. and also all of her brothers have as well.
Wow.
So things like that. There's strong family history factors, like with other things. There's so many other non-load related factors, and I think that's what we need to appreciate. Deconditioning. So when someone's had other injuries and is deconditioned, past history of injury. So we need to factor in the actual load profile with all the other factors, and that gives you a nice sort of idea of where their sort of main factors are. So load first, and then consider all your other factors.
So on the load question, then, do you feel? Although I imagine it's going to be another one of those bit of both answers, but if we think the terminology is not ideal, I know there probably is a scientific terminology I should be using, but if I think about load in terms of, say, a macro load as in cumulatively over the course of time or even within any particular session, and then I'm saying micro load being sort of the biomechanical load and narrow forces, even if we were to accumulate those, so things that could be potentially changed by kinematic and kinetic variables, which of those is primarily the issue that then leads to someone breaking down or not? Someone's foot stroke, let's say. We know that there is a change in what I'd say micro load, even though the macro load wouldn't necessarily change.
Yes. Now I get you. So you're sort of talking about, can we biomechanically sort of input and alter what's happening on a micro level? Look, it's a good question. Basically, I think you do. I mean, you can have a runner, and as you say, they could be running in two completely different ways, and that would influence the micro, if you like, load, or the load around the Achilles. So, for example, if you've got a runner who's running at the same speed and the same distances, forefoot versus rear foot, that's gonna be different loads for the Achilles. So we could. So I think you do need to. I guess where the question takes me is that you need to be looking at biomechanics and how that load is actually manifesting on that tissue, like the Achilles. And so, as part of our assessment of load, we would look at how much running they're doing, how much walking they're doing, how much other impact type activities they're doing. Then we would also look at how they're doing it.
Right.
Yeah, so you do need to look at how that's manifesting for the actual tissue as best we can at the moment. The problem is, if you take something as simple as the example I just gave you, like running with a smaller cadence or a faster cadence, if you run with a faster cadence, you'll have less loads overall, the volume of load in the Achilles, but you'll have higher peak loads in the Achilles. And which one is worse, which one is better, we don't know.
Right, sure.
So it's still difficult. And Rich Willie talks a lot about that.
And if we were to, again, as I said before, it's silly, I'm forcing it in there, but if we did top down, bottom up, and I was saying that going to head, which would you say? And if I were to then, now that we've eventually been able to define what I'm getting at with this micro macro, if you had a variable that you would say is predominantly the one that you could go to, the one you're allowed to say interfere with, what's the biggest fish to fry? Is it that micro load, or is it that more macro load? I
think it is more the macro.
Right.
I think it is more the macro. So I think I think the biomechanics changes the load, but on a smaller scale. I think what I always go for is trying to adjust the macro load. So, for example, you've got someone who comes into the clinic, they're really painful and they've got a tendinopathy that's really sort of kicking off. I would generally be quite aggressive with trying to change their macro load that is inputting into that. So it could be the walking load, the running load, whatever they're doing. So I think, yes, you can get changes with reducing their step length and cadence and everything else, and their biomechanics and shoes and orthotics and heel wedges, and that will change the micro load, but not as much as you probably need for someone who's really got quite a painful problem.
To run interference to their scheduling and all the other stuff.
Yep.
So, and I suppose then, if say they were what you would consider to be fairly optimal with the macro variables, as I say, and we'll move past those terms soon, then perhaps that would and say that there wasn't as much progress as we'd perhaps expect, or there's a plateauing, that's when zooming in that little bit closer to those micro features or revisiting them, say, that might be where it's more indicated.
Yeah, I'd say so. You'd probably you'd do a combination. I think you could argue it for someone who's not too painful. So say someone comes in, I'll give you an example of an Achilles. Someone comes in, they've got a 3-4 out of 10 hop pain. I sort of think to myself, okay, they're running a few times a week, the hop pain isn't too bad. Let's just try and adjust their biomechanics, so the micro load, rather than actually adjusting their macro load.
Sure.
But if they're very painful, then I'd go for the macro.
And so, whilst I'm having to play devil's advocate a little bit to even force another question in there, because that certainly suits my bias and my amateurish reading of the material that you and others have put out there, and there's plenty of it. But that is actually a little contentious in the field in many ways. There are people that fundamentally on that question, both on and off air, have said that they feel that the biomechanical variables are a key or the key feature compared to the more gross ones. So that remains a contention. Has that been something that you've found yourself swaying on over the years, or is that something that, if anything, that your reading of it is actually strongly in that favour and has been for a while?
I don't think we know the answer. I'm a very good fence sitter. You'll realise, Jack. I don't think we know, and that's what happens when you do research, because you realise how thin on the ground we are with a lot of questions. I don't think we know. Look, I think it is a clinical question of contention. You're right, because it is such a clinical sort of sphere discussion. We're not having these discussions based on evidence, and I think that. From experience, I probably have gone more towards the macro. Not that I advocate resting people, or not. People should stop exercise and stop running. But there does come a point when you're sort of needing to take a break from things, because people's pain is, at a point where you need to address it in that way. But I would always advocate to also address the micro loads, i.e. the biomechanics. So that I think is important. I guess what I'm saying is, at a certain point, you do need to just stop them from running.
Sure. Okay. There's a red line that occurs there, where you can't tinker with all the small variables enough to then make it still worthwhile doing it. No, that's exactly. That makes sense. And with regards to you mentioned before the effects all over the body, and that's one of the things we started with, because you said it's why it's been able to not only pique your interest but keep your interest, is because it's a topic that it's not as if it's got an obvious close point, and not at least in the foreseeable. How different do you feel upper limb and lower limb tendons are? It might be from my own naivety here, but my understanding, when your name to me is synonymous with lower limb tendons more so than, say, upper limb tendons. So unless I've missed a huge body of your work, then that's to my mind where it is. But did you feel that they are fundamentally different, and if so, how so?
Look, I think that there are differences. There definitely are differences, and some of those are emerging now with some of the evidence that we have. I don't think they're fundamentally different. I think they're. I think the principles apply. A lot of the stuff that we've talked about, cognitive rich rehab, which I'm going to use a lot going forward. Cognitive rich rehab, that absolutely applies. There's no doubt. Possibly some of the ways in which you do it might be different, but I think there are more similarities than differences. People talk about potentially more sensitization in the upper limb. That could be true. We again, we don't have the strength of evidence to really know that, but it could be true. People talk about the load that is required in the lower limb is greater, and the load the lower limb sees is definitely greater as well. So probably that influences your rehab, without a doubt. But I think the underlying principles are pretty much the same. There's not a lot of difference with the underlying principles. But you're right. My work is mainly lower limb, but you haven't missed anything that I've done in the upper limb, but we are starting to do a lot of upper limb work now. So I've got a couple of students focusing on upper limb. I'm interested in the upper limb mainly because I think there's an opportunity to change practice in the upper limb. So, for example, there's a lot of surgery that gets done in the upper limb that is possibly preventable, in my view. So, when you're looking at shoulder and rotator cuff tendinopathy, so that's something that I'm really interested in. Also, patients seem to move towards surgery very quickly. In Australia anyway, with things like rotator cuff tears, where surgeons will say, right, we need to repair that when the evidence really isn't there. There's actually, and that's something we're trying to change with direct patient-facing education that we're developing to tell them that, look, if you've got a tear, it doesn't necessarily mean that you need to have surgery. Sure. Okay, so the messages like that patients really don't have when they just go straight to the GP, straight to the surgeon. That happens a lot in Melbourne, unfortunately.
Right, I see. Okay. Fortunately, people listening in the UK will probably recognise that while still a problem as you're describing it, we also have got increasing amounts of pathways to try and have at least conversations that bridge that gap. Not that they're necessarily different conversations some of the time, which is why we need reform, but I won't get into that. Essentially then, when it comes to the upper limb, lower limb tendon thing, one of the big things, apart from greater trochanteric pain, one of the diffuseness of, say, rotator cuff-related shoulder pain, tendon pain, and, say, an Achilles, that's often what's pointed to and why people want to then make what is sometimes an assumption, but still a logical one, about the sensitization of that area, classically considered a heterosynaptic spread is the argument with regards to the neurological diffuseness of that. What's your take as to why certain body parts seem to be more predisposed to that than others?
Yeah, look, it's certainly the case that the shoulder is more diffuse, generally in presentation. Possibly, I mean, the elbow can be, and then sometimes it's not. The gluteal can be, the hamstring can be. But when you get down to the patella and the Achilles, it's not. It's often very localized pain, and it's different. It is different. They don't tend to be diffuse presentations ever, or hardly ever. So there are differences from presentation point of view. It could be related to the actual tissues that are generating the symptoms. So, for example, in the shoulder, it could be, you've obviously got bursal tissue. You've got other tissues around there that could also be pain generators. We see that with Achilles when you've got sometimes a retrocalcaneal bursa. It could be more diffuse symptoms. We see that with certainly the fat pad around the knee as well. So it's potentially a tissue generation. It's potentially, as you say, more of a central phenomenon where they've got other sort of pain mechanisms going on. So it's I think what we need, we don't have good ways of differentiating at the moment the differences, so we do need to learn about them. In the meantime, probably a clinical point that I sort of talk about when I'm teaching about these things as well is if you've got load-related pain that seems to be consistent with some of the tendon sort of presentations, load-related, proportional load-related activity pain, so those types of features, once you've got those, you could probably treat it as a load-related problem and a tendinopathy problem. So you don't need to be too. I don't think how diffuse the pain is matters too much in that context. So it's more about saying, okay, yes, some are diffuse, but it probably doesn't matter, as long as you've got the other signs there.
So I quite like that as a term that could be almost part of an umbrella, is that load-related shoulder pain, load-related knee pain, or tendon pain. How would we come to define that to some extent when we're then doing a clinical assessment? And so this is how I'm going to try and bridge the gap between diagnosis and treatment. With that load-related, that would be how it responds to certain load-related tests in clinic or elsewhere, or even teased out of the subjective. What is it that's indicating that most for you? And I'm going to naturally then weigh us into any specific test that you feel that reveal itself to be load-related in the specific sense.
So I think probably the things that I go to the most are the load tests. So any progression of loading for that particular tendon. So I'll use the Achilles as an example. You would do your calf raises, and you'd do them as a progressive thing. So double leg, single leg, overstepped or faster. Add some weight to it, and see if you've got any reproduction of symptoms. And that gives you that proportional load pain relationship. You then go to things like hopping and start doing some submaximal hopping on toes, hopping forwards, backwards, and again trying to get a sort of proportional relationship. So those things, I think that can be helpful diagnostically, because once you've got a proportional relationship, you sort of start to think there's something going on with that tissue. The more load you put into it, the more it's sort of complaining. So that makes sense. It has been demonstrated to a certain extent that is a sort of diagnostic sign with some sensitivity, specificity, particularly around the Achilles mainly, load test. But then so that's sort of the basis of your assessment from a diagnostic point of view. But there's a whole range of subjective factors as well. So, obviously we know that tendons are, gradual onset type injuries for the most part. We're looking for a change in their activity and the change in their loading. So change in the loading that you would relate to a tendinopathy. So for example, if it's a gluteal, have they started to walk up hills recently or done any different types of activities that could relate to that? Warming up behaviour, so the tendon tends to warm up with activity. Also, morning stiffness is or a rising pain and a rising, similar to what you get with osteoarthritis and other conditions like that. Which is, just crossing over into one of the points we talked about earlier. One of the things about inflammation, because that's a very inflammatory type.
Sure.
So people talk about. So then you've got to, as you say, look at some of your tests as well. So you've got tests that you can do to confirm whether someone has pain, and in the lower limb there's not many, and they haven't really been tested very well. So things like the ARC test or the London Hospital test around the patella and the Achilles, things like the flexion, abduction, external rotation tests around the hip and the gluteal. So these is some of the sort of special tests that I guess you could say are out there. And again, there's some sensitivity, specificity data for some of them. The shoulder is obviously where it all sort of, there's lots in the shoulder. And Jeremy Lewis talks a lot about these, and talks about them as special tests that are not very special at all. And I think that's what we have to accept with a lot of these. They're really limited. So for me, diagnosis has to be based on. You have to make a good effort to reproduce pain with load.
A special test and a special research finding that then has gone as close to what we can consider healthcare viral as has ever existed is the response to isometric load that has then been considered to be both an indicator for treatment, but also as a diagnostic factor. The suggestion by Jill Cook at the point of this being released was, and I remember, and I'm going to butcher the quote unfortunately, but it was along the lines of, if there isn't a decrease in symptomology, it is not a tendinopathy. It was a suggestion of it both being diagnostic and it then being an indication for treatment, which I found interesting, and it certainly, that was sufficient within certainly someone who's a world-leading expert in that space for that to have then been gospel since. So that as a very tempting special test of a sorts, because it came of a research flavour, and it wasn't like another an orthopod that had put his name on something. This was something that had a logic that seemed to emerge from what felt to be, in Jill's case, the evidence. What's your take on that in both specific terms and the utility of isometrics more broadly?
I think that based on what we know at the moment, it's and based on what we see clinically and what a lot of people. And well, actually, you probably could say based on some of the current evidence, I don't think that stands up at all. I don't think that we can say that if someone doesn't have a response, that it's not a tendon problem. Equally, I don't think it's specific to tendinopathy, so you can have responses from pain from isometric exercise from other things, other conditions. So exercise can be analgesic, and that's well documented. If a tendon doesn't respond to isometric, so you think it's a tendon, and you do some isometrics and it doesn't have a pain response, no. Do not, don't go down the path of thinking that is that is a sort of, hang your hat on that. Based on current evidence, I think I would probably say we test the sensitivity and specificity of it. If that's what we need. You need to do a study where you've got two groups. You've got a group that has other types of knee pain or no knee pain, tendinopathy, patellar tendinopathy, for example. You test that sign and you see if it stands up, and that's the only way we can know really if it does stand up. But until then, I would be very cautious about using that sign. In terms of the broader application of isometric exercise, it is extremely useful, isometric exercise, but not in the way that it's currently being used, I believe.
Right.
So I think we've got ourselves just really tunneled into this view of isometrics is for, starting off rehab, and it's for this initial pain response, and that's why we're doing it. Initial sort of short-term pain response, that only really stands up if you're dealing with athletic populations. I mean, when in rehab do you really need to give someone a short-term response with pain? It's hardly ever. I mean, most of the rehab that I'm doing is patients that are not responding or have been broken down for a while, and these people don't care about short-term pain response. They want to get better.
Sure.
They want to get better. They want to get back to playing, back to doing stuff, back to walking. Short-term pain response is not really important. So I just don't see the value in the clinical setting of having something like an isometric that's going to give you short-term pain response. What it's about is progressively increasing load tolerance. Now, isometrics can be part of that. And it's part of that if there's nothing else that really is they can do, because they're so irritated. So they can start with isometrics, progress on to other things. But, certainly concentric, eccentric is the main thing, the staple, and the thing that we do to develop load tolerance. That's the most important thing.
So before we rush too far into that, because that's obviously a really important core of the sort of what should we do then. But were you then, whilst I can understand what you were meaning with clinical utility and the patient presentation and the specifics, if we're going to be patient-centered, which we should be, their goals are very rarely, can you make this feel nice for a bit? I get that. Is that you making the case that even if the proposition that it is as analgesic as is said, then say what you say, or is it that actually you're granting something then that you don't necessarily believe is the case from the literature as it exists? So how analgesic do you feel isometric loading is? I'm sorry to not have a skip past that, but I want to see. I want to see how whether you're granting one or neither of premises.
No, that's a good question. Basically, I think that on the current evidence, I mean, a lot has been said on the current evidence, and even editorial was written recently on the current evidence by Karen Silbernagel and Bill Vizencino and others. So I think it's pretty well established that the only study which has shown dramatic reductions is the first study in the patellar tendon, and this is a dramatic reduction in short-term pain immediately following the isometrics. Most of the other studies that have come out subsequently have shown that isometrics can benefit, but sometimes they don't work, and sometimes people don't improve in terms of their symptoms straight after, and that's been plantar fascia and Achilles and various other areas. So I think we have to, as scientists and as clinicians, say at the moment that we actually can't say that isometrics is any better than any other type of intervention or is guaranteed to achieve some sort of pain response in these people. So really, this is what I talk about when I talk to clinicians about this is, let's not get carried away. Let's just think about load as something that can potentially improve people. We currently don't know what the best way to do it is. Try isometrics, try isotonic. We certainly don't know. One of the things we need to understand is what are the mechanisms that drive some people improving and other people not improving.
Yeah.
So I've got a couple of students who are working on that question at the moment, because I think there's a lot of cognitive bias as well. So for example, if you prime someone and say to them, look, we're going to give you this isometric exercise, right? It's going to be, you're going to feel much better after. It's going to feel really good. Obviously, that's going to influence their response to that. And you might do the same thing with an eccentric, and it has the same response for them as well. So
I've seen that done as well, where people and partly because of, as I said, this viral meme-like nature of that particular advice that suited all of our biases, as we tried to move away from what felt like passive interventions and then giving out this active intervention that was going to be analgesic. People then have even primed patients and suggested that this is your medicine, or this is the what we consider to be mechanistic pain relief of a specific nature is naturally going to skew both clinical and even research findings, if not controlled for. So, no, it's really, really interesting, and thanks for doubling back with me on that. I feel like the treatment of tendons has gone from, not in a matter of years, really. It's not that many years back that I recall having a go-to sort of cheat sheet almost, that you could hand patients this booklet of a journey, an algorithm for. It used to be like, wow, brilliant, put the kettle on, it's an Achilles tendinopathy, and here's the Alfredson program, and certainly a modified version of it, where that was just going to be like, well, do you even need to see me again? It was almost like such a penalty kick that was naive, of course, and then, because of the question marks that we've joked about over this podcast about the fact that we know less than we used to think we knew, it's then become more and more controversial. That means that whilst it suits my bias because there's more questions that can be asked and answered, what are the loading styles and parameters that we feel now are at least closer towards the answer than we were back then?
So I guess the most important thing with that is we don't actually. There's no best way of doing it. So there's no, eccentrics. We thought initially was, as you say, we thought this is it. We've solved it. This is but we know now it's not the case, and it's there's other people that have tried different types of loading, heavy slow resistance, and the Silbernagel's got her approaches, and basically the unfortunate thing for me as a researcher and clinician is that it basically all. It unfortunately doesn't seem to be a best way of doing it, and they all seem similar. If you load someone for 12 weeks, they seem to get some sort of positive response. They seem to be a bit better. We don't know the parameters. So, for example, one of the things I talk about a lot and believe in is heavier load, and that's based on the underlying knowledge that tendon adapts to heavy load interventions, but there's no clinical evidence that heavier load is better for pain and function and patient-important outcomes, because patients, as you say, they're not interested in adapting their tendon. So that's something we're trying to work to improve with some of the work that we're doing, but we still don't know fundamental answers like, is heavier load better than not heavier load? We still don't know those.
So the high load logic is based on an overload remodeling process. Is fundamentally at the heart of it. That doesn't surprise me in terms of lab-based and even research-centric thinking, but also clinically it also mapped onto what I felt was almost like a let's train beyond the capacity you need, both in terms of not just, I'm not thinking tendon-centric there, I'm meaning macro again, I'm going to use that term again, but just in terms of what this human needs to tolerate, it almost felt like a sensible, like, cheesy, but reach for the stars, land on the moon type logic, where you were always pitching for that. So I never really thought of it as being as centric as that. But from what you're describing, perhaps I've mistaken the fact that logic included some research that suggested that it altered the patient-specific or patient-relevant measures that we'd care for, whereas actually you're saying that the high-load logic was actually a remodeling logic more than it was patient-centric.
Absolutely. So it's all based on it's based on muscle and tendon adaptation. So there's no evidence in the lower limb that heavier load interventions are any better in terms of pain and function at all. So we just don't have, and that's a huge gap, I think, because a lot of people, everyone recommends heavier progressive load. So but we just don't have any evidence to say that's the way we should do it.
What is it about load that can hinder and that load that can heal? And if it turns out that the variables that you and your team are investigating, is there a potential that in treating tendons, we're actually hindering tendons because essentially the dose response might be actually much narrower? How can it be both?
Yep. So basically, the main differentiating factor seems to be speed. So if you bring on something real quick, so a quick loading as in a stretch shortened cycle, it seems to be more likely to be damaging. Whereas if you do something very slow, like a slow progressive, heavy slow resistance or any type of slow exercise, the tendon doesn't seem to have the same problem in terms of potentially leading to injury. So I think that's the key differentiator. So if you're doing slow things, it is very unlikely to be damaging. The only time when it may be is when you're doing very progressive joint ranges where you're really getting a lot of compression in the tendon as well. But generally, you're safe doing those things, and that's what we do in rehab. And then rehab also crosses over to the fast things because we need to do hopping and jumping and progress them back to running. But that's the time when they're able to do those things and progress into those things safely.
Yeah, and heavy relative to what was one of the things that obviously I want to talk about is that how individually specific does the dosage need to be is one of the big challenges to this. So and if in case I forget, I will double back and sort of feel like what's your hot take on why loading works or helps. But on that specifically though, what do you feel is your go-to thing both in clinic and from a reading of the research?
So I think you need to have individual goals, and they need to be factored in basically to what you think that individual can achieve. So I call them maximal strength goals that I give to all the tendon patients. So every tendon patient that I see in the clinic, they'll have a workup of their local muscle tendon unit strength. So say you've got an Achilles, you'll really assess their local sort of calf strength very well. Patella, their quads, and etc. And basically just work that up to the point where you've got a really good number and exactly how strong they are. And it could be from a leg extension, could be from dynamometer, it could be from whatever you've got access to, and then use that as an outcome. And this is where the experience comes into it. So you need to then say, okay, this is where I think you need to be. This is where you are, and that's the problem. We don't have that data except for the Achilles. One of my PhD students, Igor Sancho, he's basically looked at a case control study, Achilles runners versus runners without Achilles problems. And he's found that on a seated calf raise, there's the Achilles people were able to push 1.1 times their body weight, whereas the ones without pain were able to push 1.4 times their body weight. So we use that as an outcome. It's just the starting point, and it's just one population. But
so there isn't an existing base of normative data that can be used to compare, which is why we need to make it individually specific. So in this instance, if we've got an asymptomatic contralateral limb, which is always glorious when that happens, isn't it, to compare to, but similarly challenging as well because people are asymmetrical, as is their nature. How relevant is the deficit then between affected and unaffected limb?
Yeah, that's a tricky one, because we do also have some evidence that even if they have got this nice, unaffected opposite limb, they can still have strength deficits on that side.
Yeah.
So it's difficult to actually use that. So we
Okay.
do use that a bit, but we really go more on, okay, this is sort of in the clinic. I've sort of developed, and this is what I say as a sort of caveat or declaration when I'm teaching people. This is all based on experience. So with a hamstring patient, I know if they're a runner, on my recreational runner, say on my leg curl machine, they should be able to get to 15, 20, 25 kilos. And that's just what I've seen over the years.
Right.
But it's not, we do need to be able to, I think it helps patients to have a number, because it motivates them.
Sure.
Motivates them to say, right, this is what I need to. If you can say to a patient, look, you're pushing 5 kilos in the leg curl, you need to be pushing 20, 25 kilos. That's what all my other running patients are doing.
Right.
It motivates them.
Of course, yeah.
It's good.
No, I like that. Yeah, dangling the carrot. It's a smart move. But if we were to think then about, and I'm not going to, because I respect and agree with your answer with regards to the individualization, but let's therefore try and force some sort of loose case study into that then, as to when people are naturally having to pick a dosage. They have to, the rubber hits the road, the patient says, what should I do then? And they can choose to give them a movement to explore within parameters of do this until it hurts this much, or do this until it feels this way, or give them a range of, I'm trying to say, or they could be quite specific and say, this is how much I want you to run or not run, this is how much I want you to do heel raise or whatever it might be, decline squat, whatever it might be. How is there a ballpark then that we can that you use that can help you to try and identify that starting off dosage and then into how you progress or regress that if needs be?
Starting off dosage more for the running side of things.
Let's make it simple then. Yeah, let's say a runner.
So it would depend on the baseline. So whatever. So I would generally, my approach is probably in between what you've described, and that is overly regimented and sort of no structure at all aside from pain.
Yeah.
I would probably say I think most patients do need some structure, but you need to be able to vary that as well. So they do benefit from a little bit of input to say, look, this is probably a safe range, just go between here. So, for example, it might be increase your running from 1 to 3 minutes per run or something like that. But I think the most important thing is to understand what the baseline is. And the baseline is whatever run they're able to do, or it could be walking, whatever, so you might ask your walking patient, what's the longest walk you're doing at the week, in your week at the moment? They're recovering from a gluteal problem. Their longest walk might be 15 minutes, and that's all. Then you can start building from there and start doing that every second day. So I think, again, we're moving into a technology phase, and that's helping us. So we use step data, so how many steps they do per day, and that can allow us to quantify how much walking they're doing, and using that to increase their loading. Running's easy because you can do minutes, and you can that's easier. Walking is a hard one. So I think they do need structure. But they need to be able to self-monitor and be able to respond to whatever their symptoms are as well.
And when we're then identifying that early stage, how individualized is that part as well with regards to there's a set of options that come available to us in clinic for what to dish out initially, and is it slow, heavy loading? And obviously the heavy part you've got sort of answered as to why we're making that individualized. Or because sometimes I feel obliged to do that rather than get them to do what might be a more interesting or entertaining dynamic movement that feels like it's not. And that obligation perhaps I've put on myself, and it's not as evidence-based as I once thought. So can you give us a clue as to what you're doing in your clinic when you're doing that first dosage? Is it a mix of the boring and the interesting?
Yeah, I think the way that I look at tendon rehab is it's the fundamental job of a clinician doing tendon rehab is to load the affected muscle tendon unit. And that's boring. You're right. That's very boring. So, doing seated calf raise or doing leg extension or doing leg press or doing, doing even calf raises in standing is boring. But I think that's the fundamental sort of building block. Then you get into all your other stuff. So you can, and it will depend on their initial presentation. So you might be able to do some dynamic, weight-bearing exercises day one, depending on how their function is and how their pain is. Or you might need to go through a phase where you've got all the other stuff, the building blocks first, and then you build them up to that. So it does depend.
So it's not an absolute no inherently, as I've potentially allowed it to become, unless they have any sort of effects down the pike. Really, it's not as if they need to qualify themselves for dynamic and more interesting rehab.
No, I don't think so. I don't think so. I think pain is the best guide we have. So how much pain they have when they're doing it,
and latent as well.
Yes, yep.
Okay.
So the pain during, and then the 24-hour response thing, as well as the pain they have during.
Okay, no, that's really interesting.
Yeah.
I have to then ask what is never a pleasant question, and one that I got asked in FAQs almost recently, was why do you think loading works or helps?
It's a really good question. I work with people in Melbourne, researchers, really good, well-established musculoskeletal researchers who don't believe that exercise helps pain, because they can't see the mechanism. They can't see. They sort of say to me, how can you get pain being helped with exercise? Exercise is for developing strength and developing those things. So, obviously, what we know is that when you do tendon rehab, people's pain improves, their strength increases, possibly changes to the tendon. We don't know which of those feed into pain change and which of those are important mechanisms. So, I definitely think exercise is having lots of consequential positive effects like strength, and people feel better and they feel stronger when they do it. But in terms of how does it change pain and does it change pain, I think it does, but we don't really know and understand at this point.
What would be your best guess in that direction then?
I think there's probably cognitive changes, so confidence, reduction in people's fear of movement, fear of loading. So I think there's cognitive top-down type changes that occur. I think that is probably a big one.
So that's like a trained exposure, essentially. Like they've essentially had that natural process in which they've been doing a task that was otherwise painful, that they've then realised under supervision, especially that well, if this expert feels that this is safe to do, then perhaps it is, and that's building into their subconscious, etc. That's the mechanism you're describing.
Yes, I think so. I think largely that's a key one. I think that is one, and then you probably get some bottom up, so strength changes, possibly some tissue adaptations as well. So it's you do get patients, and you sometimes in clinic it becomes clear which ones are operating. Like you say, you've got the expert effect where you get someone who you just blow them away because they can't believe you've said, they can do this calf raise, and suddenly their calf raise pain goes from 6 to 0 out of 10, within a session, and that's got to be top down. But then you get other people that are a slower burn, and maybe there's some bottom-up mechanisms happening. So it's probably a mixture of different mechanisms.
And so, of those, one of the big bottom-up mechanisms we have talked about is this concept of where a tendon might degenerate or become deconditioned in a specific sort of cellular level, even mechanism where the matrix breaks down, etc. Between those two, then there's the muscular units that, of course, we're describing, and in your answers you've been making sure you said tendinous muscular units. But when our last specifically tendon podcast was with Seth, the second one he did, which was timed because that was when he felt he could reveal what was one of his sort of pet theories at the time, which was this concept of the strength exposure to the strength improvement, of the muscular unit was then almost a shielding effect that then stopped it then locking on and the tendon having to do more of the work. Whilst I'm not necessarily feel free to, but I wasn't inviting a specific critique of that as a theory. How relevant is that in the mechanisms of effect, in your opinion?
Yeah, look, I think that's a reasonable argument. I think the strength in the muscle tendon unit is going to improve the ability of that muscle tendon unit to absorb load, ultimately. So I think I don't know whether it's a shielding effect or whether it's just how well it's able to absorb load and how efficiently it's able to do that, but certainly strength seems to be a big factor. So people that are very weak, and it's not all tendinopathy patients are very weak. Some patients, you get a good proportion of them that are extremely weak, and they seem to benefit from developing the strength that they need. Definitely. So whether it's a shielding effect, as Seth has talked about, or whether it's other effects, other mechanisms in terms of absorption of load, these people, or whether it's just the fact that the load is actually having an effect on the tissue itself, i.e. starting to adapt the tissue in some ways, we don't know. But certainly loading the muscle tendon unit, there is a muscle tendon potential for some mechanisms there.
Okay. So of the three things then we've talked about, the actual tissue characteristics of the tendon could be sometimes altered by load parameters. Strength of the muscular tendinous unit for the reasons you've just described, and then the exposure and the cognitive factors that we started with. Are those the big three? Have we missed any other factors there that are key variables as to why?
They would be the ones, I reckon.
Yeah, you think that covers it? Good, lovely. I didn't want to skirt off that because I know it's a really, because often our listeners will be keen to, when they understand the mechanism of effect there of both the cause of the problem, let's say, and the mechanisms of the interventions, and perhaps they can help have the confidence to build a rehab program.
I thought you were going to force me to pick which one was the most important.
Do you want me to?
No.
Well, you've invited it now, but yeah, I didn't. I think that would be excessively cruel even for me. But unless you want to, then
I just think it's difficult. It's really difficult. So as you know, as we said earlier, you might get clues that one is more important for some people.
Yeah, if someone crept up behind you saying, "Funnily enough, I've been handed this down by a mythical being who knows the answer of those three," and forced you to give your best guess as to where. And this isn't just the now. I mean, in the future, where do you think that the evidence will point us of those three?
I think I would say I'm going to sit on the fence here, and I'm going to say they're both important for different people, different populations.
Okay.
But I guess this is the crux of cognitive-based rehab.
Cognitive-rich rehab.
Rich rehab. Thank you. I've almost adopted it. I think this is the basis of it. It's basically you need to do both.
Sure. No, that's that's not actually as much of a offence as it maybe sounds, is it? Because you're suggesting that in time we might recognise that for different subgroups the key mechanism is different, but the intervention might seem very similar, and so we need to identify that, and that's like a post hoc stratification that we might need to do to understand which mechanisms are in play with which population set. So no, I do like that answer. So I'll leave you with it. When it comes to adjunctive treatments, which ones meet your personal threshold for integration into your care?
I think adjunctive treatments. I sort of categorize them as they're all, the evidence for all of them is not great, and that's the important thing to consider with those. So the evidence, we don't have any adjuncts that are very evidence based, aside from potentially shockwave. Shockwave, there's some evidence that it does work.
Do you do it?
I do. So I do shockwave, but the way that I talk about the adjuncts is that they're all in what I call the neutral zone of evidence. So we don't know they work, we don't know they don't work. So they're sort of somewhere in the middle. So and what I suggest to clinicians, even though I don't do manual therapy, I don't do dry needling myself, is that if we don't know that it works necessarily, we don't know it doesn't work. If you think that it's going to help an individual or you're getting a good response, then fine, go for it, try it. But make sure that you're doing all the other things as well. You've got to make sure you're doing the other treatments that we know are going to potentially help them more. So so this is sort of how I try and rationalise it, because clinicians, they use these things, they see benefit from them. I don't stop them from, I don't say, look, you shouldn't be doing that. The evidence isn't clear. If it fits within your model, fine. What I personally do is so lots of education, lots of rehab. So the exercise-rich rehab again, but I also do. As an adjunct to that, I would do tape. I would do heel wedges. I would do lots of shockwave. So those types of interventions fit in, and it's generally in that initial period when you're trying to improve their symptoms. So it might be the first 4 weeks or 6 weeks when they're really quite symptomatic. So that's sort of what I would use.
And so shockwave meet your threshold across a variety of pathologies?
Yeah, I do it for. I do use it for most of the tendon injuries that I see. I think there's not compelling evidence that it's different to placebo, unfortunately. When you look at the placebo control studies, I do believe that is an important research question. We need, and even with exercise, we need to answer the question of whether treatments that we're doing are different to placebo. I think that's critical, because we need to know whether there are sort of specific effects within these treatments. So if you look at exercise, there are 2 placebo or sham control studies that look at exercise for tendinopathy versus placebo or sham, and both show that it is no different.
So let's say that on a patella, let's just use it as an example, patella tendinopathy that you're seeing, what is it about shockwave that met your threshold that dry needling hasn't?
Well, this is the thing. It's I can't say there's any difference between them from a mechanisms point of view. Shockwave is the mechanisms that the people that sell shockwave talk about are quite, I guess you could say, not supported by human studies. So, adaptation, healing of tendon, changing the actual tendon. It seems to be a very powerful pain modulator, and that's how I use it. And that's probably the same as dry needling.
Sure.
So I'd be a hypocrite if I was to say, look, do shockwave, don't do dry needling, or dry needling is not as good as shockwave. It could be similar in terms of its mechanism. It's just that I have access to shockwave,
sure,
and that's why I use it. So I think it's anything you can do to modulate the pain is, and if it works, fine.
And so, if someone is time poor, you're describing this truly in the term as the term adjunct is meant, which is that it is completely supplementary. And if someone is time poor, it should be the first to go of the things you do. Is that about right?
Yes, absolutely.
So another famed adjunct in that space that we haven't covered is injections, or what could be considered, even if not adjuncts, but another threshold when non-responding is occurring. What's your take on both the yes, no have indicated, and then of course what substance?
Yep. So basically, injections, again, it's one of those adjuncts where there's the evidence is poor. So there's no injection that we can say at the moment is something we should recommend. PRP we know doesn't show any benefits to placebo in most of the better studies. So there's I think with injections, you have to make an argument, as you say, when someone has failed treatment, so they're 3 months down the track, you've tried everything, then you might be able to justify it. The only thing that does work from an injection point of view is steroid. Steroid absolutely works in the short term, but can potentially harm in the long term. So that's the unfortunately the double sort of double side of steroid. In my practice, I'm happy to recommend an injection at 3 months failure if you've tried everything else, you've done the best rehab possible, and then it would be either a steroid or a PRP. That would be largely dependent on the person, their preferences, as well as the person they're seeing. I don't think there's probably steroid is if you're looking at pain response, is going to be the one that's going to be easier to argue. But yeah, look, it fits into the whole the whole sort of pathway. But the evidence it does need to be improved. One of the problems is potential harm with steroid in the long term.
I was going to say, steroid's clearly not a hard no for you. It's something you try to avoid, but essentially you then have sent patients for steroid when they're in agreement for that. Especially, I imagine there's a timeliness factor with some of the athletes you'll see. I imagine it's in part because they are particularly bothered about that short and medium term and are willing to take the longer term risk. So it's less of a hard no. If I was to, although I hope this doesn't happen and we're touching wood and tempting fate, but would you have a steroid, if you failed your own expert rehab, would you have a steroid injection into your Achilles?
That's an interesting question. I probably would. I think, yeah, I probably would. Not into the Achilles, but around the Achilles.
So bathing the carotene on
around. So generally, yeah. Look, I would probably have one. It's funny. we're doing a trial in Melbourne where we're doing a high volume injection, which is something that's been popular here in the UK. We're looking at sham versus high volume injection with steroid versus high volume injection without steroids. So 3 arms. And hopefully that will show some promise as an injection we can recommend for Achilles. But as part of the sham development, we're starting to recruit in August. I volunteered to have an injection for my Achilles and tested the sham, which was 10 mils of saline between the skin and the Achilles. And basically since then, 2 months ago, I've had Achilles pain.
Oh, really?
And I've never had it before.
Oh, interesting.
So now that I run, I have sort of 2-3 out of 10 Achilles pain. It warms up as I go, so it's been interesting to see sort of what it feels like. But you do worry. One thing that's taught me is that every time I'm running along, I start to think, shit, am I going to rupture this or what's going to happen?
Well, that's what I wanted to try and press on a little bit is that I feel like it's fair of me to read into your answers enough to think that you must at least be suspicious that there's a bit of scaremongering going on for you to even for it to even be on your radar that you would consider it both in you, in patients, in loved ones, or whatever it might be. My question. Clearly, you're not someone who thinks that steroid is sufficiently toxic to that area that it would be almost an inevitability or a high likelihood of rupture down the track. Whereas others have been as forthright as that. So, am I right to read that into your answers?
Yes, absolutely. Look, I definitely think that the risk of rupture is not so much the problem. The problem is the risk of relative less benefit or the risk of relative harm in the future. So possibly you have a steroid and then you're fine, and then 12 months down the track you're worse again.
Yeah,
so
the recurrences of symptomology.
Yeah,
I shouldn't
exactly.
really, rupture was a different question, really, wasn't
Yeah.
it? But Vincenzino's work, particularly in and around the lateral elbow, is where that's almost most overt in its mechanisms. Do you feel that those mechanisms that are purported there and that trajectory is something that does transmit elsewhere in the body or is likely to in the future research?
I am not so sure.
Okay.
I think it's quite possible the elbow is different because you've got a smaller, tendon structure. You've got a different tendon fundamentally to something like a very large patella or Achilles. Certainly, we've done one steroid for people with patella, and they've responded well. I've had, it's not uncommon for us to, when I say us, some of the sports docs that I work with in Melbourne, to add in a steroid injection as a once-off during the rehab process if they're finding a point where they're plateaued, and it seems to be fine as a once-off.
Right.
So I don't, as a once-off last resort, I think the risks may be small, but we still do need to determine whether that's true.
Okay, no, that's interesting. And a lot of people hold out a lot of hope for regenerative medicine, stem cells, etc. Now, to my mind, just to kick us ahead a little bit on this, I imagine the logic, as far as I can tell, is quite tissue-centric in that it's the only mechanism that it could truly affect is the idea that there's some relevance to the pathology that you're trying to regenerate. Is that something that you're interested in, paying attention to, and do you feel like you've made referrals in that direction?
Look, I think with PRP stem cells, all the biologic type things, it's not. I think the underlying rationale is a bit flawed, and that is that the healing process will be stimulated by just putting something in there. I think it's healing is a lot more complex than that, and it involves load, mechanotransduction, stimulus. So I think that's what we need to get right.
Sure. So their best chance would be to dovetail it with load-based interventions anyway, wouldn't it?
Exactly right. So I think that's the direction that should go in. But at the moment, it doesn't fit into. It's either in the neutral zone like stem cells, or it's shown that it's not effective like PRP. But I would really caution against stem cells because they're so expensive and we just don't know if they work.
Yeah.
So at the moment they really shouldn't be selling them for $3,000, $4,000, $5,000 a pop, whatever they do.
No, that's fair enough, and that's where it does map onto ethical questions, doesn't it? Compared to and it's almost a more reasonable justification of things like shockwave and dry needling, which are a relative in expense and only especially the former coming down in price in time. So no, I can certainly understand that. It maps me onto what I think is probably my last or one of last questions, which is what do you feel the future holds for tendinopathy, both in terms of research and tendinopathy practice, which I know you don't divorce, but if you could pass on.
One of the things I'm very interested in at the moment is trying to improve what we know about exercise. So I touched on it earlier, and that is that we still don't have the answer to the question of is exercise better than placebo. So I think that's an important question for me, because if we find out that maybe it's not, then we need to distill whatever is making people better, and that could be the reassurance and the cognitive things we talked about earlier, or the education. So I think that that's one. That's one thing. The other thing about knowing that we're better than placebo is that you see what's happening with a lot of surgeries now. We're seeing that knee arthroscopies and other surgeries are no different to placebo. It's not completely fanciful to think that maybe people will turn around and say what we're doing is no different to placebo. The good thing about exercise, there's a lot of consequential positive effects, and it's relatively cheap. So I don't think we're going to be attacked that in the same way as what surgeons have been. The other area is really looking at what parameters. So, for example, does increased load or heavier exercise or exercise done over a longer period of time confer greater benefit? And then another area that I think we can improve on is, as we've touched on today, is the mechanisms. So basically, what are the mechanisms? Are they cognitive or are they tissue-based, and can we improve on those? So I've got one PhD student doing a study that I think is probably one that excites me a lot at the moment, and that is looking at very specific loading doses and the effect on the tendon itself. So doses that haven't been done before, because the problem with exercise is we never know what people are actually doing.
Right.
And we need to control the dose very carefully to be able to make assumptions about the dose response. So that's what this one PhD student is doing in Melbourne at the moment. And she's just doing isometric interventions, not because isometric is good for short-term pain, but because isometric is a nice way to control strain in the tendon.
Yeah, you can control more variables there, can't you?
Yeah, yep.
No, that's interesting. And when I think about what the answers might come from that, and if you were to try and look into the future as to they're the things you're looking into, and that's what the future holds in terms of research. What do you think the future if you had to force you for your assumption as to what the outcomes would be of that material and how that will change practice in the future?
I think we'll be more assured about exercise and how to deliver exercise, and there'll be less variability. Excuse me. There'll be less variability across clinicians in how we deliver exercise. So if you look at how exercise is delivered at the moment, it's quite diverse. And we did a survey on rotator cuff delivery of exercise and the principles people use in Australia. We've just submitted that publication. Basically, people are doing any sort of dosage you can think of. People are doing it, and it's just this whole spectrum. And it's because we don't know what to actually. We know exercise probably works, but we don't know how to do it.
Sure.
So I think that will be, and hopefully that will lead to better outcomes. The other thing that I think in the future we're probably going to get better, and I think the future of talking about the future of clinical, I think the other thing is technology, and we've touched on this as well. So technology to improve adherence, technology to be able to treat people via telehealth, and also to treat people online. So I touched on the online intervention that we're doing for shoulder patients. That's basically an online education that allows them to have the information they need to make informed decisions about surgery or no surgery. Okay. So things like that hopefully will improve outcomes for people with tendinopathy.
And what would you say are the go-to things that, outside of almost physiotherapy in a sense, is that what would be the go-to things that you would advise others do to prevent tendinopathy? What would you, I suppose, because I know that seems like a bit of a left field question at this stage of it, but it's more that it's the go-to tips of avoid these things or do these things and advocate that of your patients ongoing.
Probably the most important thing is just being careful with how you're loading the tendon. So the loading of the tendon, it's all, Tim Gabbett and his sort of thinking and views and that world where you've got to, load is, we've got to recognise load is the biggest factor. You've got to bring in the loading gradually, and that's probably the most important thing. The other thing is stay strong, know. So so that's those sort of I think arguments. Stay strong and healthy, and load gradually.
And with healthy, I suppose, I mean in there in terms of general wellness and avoiding metabolic diseases and other lifestyle factors that might influence things, although we don't know how causal. Is there could you tell the listeners as to how they can find more about you? And also what you're up to here in the UK and where they can find you.
No problem. Thank you very much. Basically, I'm doing a course series here, and I'm leaving. I think you tweeted that this is available on the 7th, which is a Sunday. I'm leaving that day.
Oh, right, okay.
Melbourne, yeah. So I'll be back in Melbourne. Basically, if you want to find out about me or the blog, there's also an online course that I do. It's tendinopathy.rehab.com, basically. So tendinopathy.rehab.com is I do a blog. It was very regular, but now it's become irregular, right. Just with all the other stuff going on. But but I basically have the other place to find me is at Monash University in Melbourne. So if people are visiting and they want to visit the lab, then come to Monash University in Melbourne. Fantastic. We'll probably get them to volunteer for a study.
All right, yeah, that's the thing. It sounds like an experimental place in every which way. So yeah, thanks so much for your time today. Really appreciate it. And whilst it's been wonderful to chat. Thank you so much for all you're doing for not just the profession but the industry at large, for really answering the questions that really I'm glad they're interesting for you as a researcher, but also they are mapping onto clinical practice more than most. So thank you for all that.
Thank you very much, Jack. Great to chat. Great to chat.
Thanks a lot.
Thanks.
Well, I hope you agree with me. An absolutely brilliant chat with Pete there. His ability to explain and elaborate on the general and the specific regarding tendons is top class, and there is so much info packed into there for you. Follow Pete on Twitter at Dr. Pete Malliaras. If you must, follow Jack Chew at Jack A. Chew. The podcast team tweet from at TPM Podcast. And my one shameless plug for this episode, head to my website, rheumatology.physio/courses, and check out where I'm going to be in the country for my Rheumatology for Physios courses. There are a few on there covering between September and next May, and sign up there if you are interested in listening to me bang on about rheumatology for a day. The Health and Patient Matters podcasts are coming at you thick and fast. Check those out on our podcast feed. There really is something on there for everyone. And please get in touch with us by email physiomatters@choosehealth.co.uk with any comments, feedback or suggestions. We have had a few emails from patients discussing what they've taken from the podcasts, and there is absolutely humbling feedback in there, and we really enjoy hearing from those patients. And if we can touch just one or two people with the information, then really that is more than we could have ever asked for. So I'm going to leave you with the cheesy sign out. You get me doing it this month as Chewy forgot to record it with Pete, and so I apologise for that on his behalf. But we will see you next month for more of the Physio Matters podcast. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.